Hello, Slush 2019. I'm Victoria Turk. I'm features editor at Wired, and I am delighted to be joined by Claire Novorol, co-founder and chief medical officer of Ada Health, to talk about how to build trust in a product. So Claire, with Ada Health, you're asking people to trust a technology product with the most critical and sensitive aspect of their lives, healthcare. Talk us through some of the fundamentals. How do you go about earning that trust?
Yes, I think absolutely key, first of all, is the quality of the product. So what we've always focused on from the very beginning, 8 years now actually, is the quality of the core product, the foundation of everything that we do, and that's our knowledge base, our reasoning engine, and how it works. You know, the clinical quality of that, accuracy, safety, continually measuring that, and continually improving it. I think second, it's about the high standards that we hold ourselves to in every aspect of the business. And it's first of all putting the patient at the center of everything we do and making sure that when you, that the assessment, the entire experience, every partnership we enter into, it's always in the best interests of the patient. You know, we only do things that are in the best interests of the patient. And then the third thing is really being very open and transparent in all of our interactions with the public, with industry, with the medical community, being very proactive about communicating what we do, why we do it.
So starting with that first issue you highlighted, the product itself, you know, the technology has to work, otherwise people won't trust it. For those who maybe haven't used Ada Health or aren't familiar with these kind of AI tools in diagnosis, talk us through the technology. How does it work and how does it compare to a human doctor?
Yeah. So Ada is an app that you can download on your iPhone or your Android smartphone for free. And you would typically use it from home or wherever you are when you're feeling unwell. You download the app, you have a conversation with Ada about your health and about your symptoms and how they're affecting you. And we've built it so that it's a very easy interaction, they're simple questions, and it's just a back and forth exchange, a little bit like when you talk with your doctor. And Ada is working dynamically with every response. Ada's recalculating and rethinking what might be going on here, what should I ask next. And at the end of an assessment, Ada helps the individual to understand what might be going on with probabilities, so a list of possibilities, how likely they are and what will be the appropriate next steps, and then can guide people to the correct care. And we work with various partners to map their services and providers to those next steps. So if you're using Ada within the context of your own health system, for example, then you may be guided directly to care that's available to you nearby and covered by your provider. And you should think about it a little bit like an alternative, a much more personalized alternative to searching online for your symptoms when you feel unwell and are wondering what to do. And everybody does that these days. That's just normal. When you're at home, you don't know what might be going on. Can I manage this at home? Do I need to see a doctor? If so, how urgently and which type of doctor? And everybody is, it used to be the medical encyclopedia on your bookshelf. Now you go online and search, but Ada is a much more personalized approach to seeking that information.
So when you're advising people what to do in a healthcare situation, you've got a delicate balance there between you want to be cautious enough that you don't miss symptoms, but you don't want to be overcautious and send everyone to the emergency room.
Yeah.
How do you kind of draw the line between those and make sure you're striking that balance right?
Yeah. So the triage advice, the next step advice, is based on a combination of what Ada thinks might be going on, as well as the symptoms and risk factors and the severity of those that the patient has entered. So it's a combination of these things that are taken into account. And the advice is really based on best practice guidelines and reviewed by a lot of expert clinicians, so that to make sure that it's consistent with those. And it's very comparable to the advice a GP would give, but if anything, we try to err a little bit on the side of more conservative than an average GP, because if it's a remote virtual system, it's based purely on the information entered by a patient from home. There are a number of variables there, and you always want to be a little bit cautious, but without moving all the way to of course, we don't want to send everybody to the emergency department or tell everybody it's urgent. We very, very much don't do that, but erring a little on the side of cautious.
So where does Ada Health see itself sort of fitting into the broader healthcare system? Mm-hmm. Is this a GP replacement?
So it's not a GP replacement. I think you should really think about it as that first port of call. So perhaps a replacement for searching online, or in addition to doing that. We do see that when GPs use an ADA assessment during a consultation, so very many people that tell us they use ADA, but then they take the ADA assessment to their GP or other physician when they go for an appointment and actually show it to the doctor, and then the doctor and the patient use it during the consultation. And we get a lot of good feedback from doctors actually who tell us, I'm used to patients coming in, having searched online, having a lot of ideas about what's going on, maybe being more informed, but also perhaps a bit misinformed at times and confused or worried by that information. But having an ADA assessment, which is far more personalised, gives really relevant information, and I can see exactly what the patient has entered, what they've responded, what ADA is telling them, and why they are asking about certain things, can really aid the conversation. And we also see in studies we do that the overall accuracy, the clinical accuracy in terms of diagnosis and management is improved overall when doctors use ADA. So the combination of ADA and doctor is more powerful than either one alone. So you sort of use the strength of the machine and what that's good at, and the strength of the human, and that combination is even more powerful. And I would just make one other comment actually, which is that there are about 4 billion people in the world who lack access to a doctor, who just don't have access to a doctor. So you can imagine the potential for technologies like ADA in the hands of people. They have a smartphone but no access to a doctor, and how much this can improve sort of access to information and early appropriate care.
On this topic of trust, obviously the technology itself, the fact that it works is hugely important. But the way people interact with you, your communications with your users also must play an important role in building that kind of trusting relationship. How do you approach that from a kind of UX point of view and a comms point of view?
Yeah, so very early on, in the process of moving from building a technology that was purely doctor-facing, because that's actually how we started 8 years ago. We started by building a decision support tool that could support specialists and then GPs during the diagnostic decision-making process. We started with a clinical-facing tool and building something that was so good it was good enough to support doctors in their thinking processes. But then we saw a real opportunity to go direct to the individual and meet them earlier in their healthcare journey, so enable better, more appropriate navigation of the system and identification of what might be going on as early as possible. And we had to make this switch over from being a very clinically driven, medical-facing product to also launching an app that was available to the everyday individual. And that requires, of course, quite a different approach when it comes to UI and your messaging and so forth. And that was about 4 years ago now. We did a lot of work on how to build an interface that was friendly, yet at the same time authoritative and trustworthy, and using very strong clinically, but at the same time using very simple, easy to understand, patient-friendly or person-friendly language. Making the interface as simple as possible, as not just the language, but one question at a time, very clean, and so forth. So we did a lot of research before we built that product, and then a lot of testing early on, and we continue, of course, to do a lot of testing, and we've got ways in the app that people can give us feedback. We learn from things like there's one option after every question, I don't understand, explain, tell me more, I don't understand, things like this. So we can see quickly if there are certain questions patients aren't understanding, and then not only explain there in the moment so that they have a better understanding, but go back and improve those questions over time.
And your background is as a medical doctor. You came at this from a sort of doctor's experience, not a technologist necessarily. How do you think that's coloured your approach to that?
So I mean, from the very beginning, I worked as a paediatrician and then as a clinical geneticist in the NHS in the UK, seeing people with rare conditions, and it was very normal for me in my everyday work as a geneticist to see patients that were a diagnostic conundrum, that were difficult cases in terms of getting to a diagnosis. And I'd sometimes see patients who'd spent 20 years with the wrong diagnosis or without a diagnosis, who would come into the clinic, and then it could be a real puzzle at times. I'd need to discuss difficult cases with doctors in my own department, and then every 3 months we'd meet in London to discuss our difficult cases and get the help of people sort of from all around the country who are experts in that field. So that was where I came from when I met my two co-founders and we started building out this technology from from having experienced firsthand from a doctor's perspective these challenges and difficulties and how technology could potentially support that decision-making process and make it easier and faster and more accurate. And I think that was very important when we were working with doctors, and it remains important when going direct to the consumer. But of course, what we've had to do increasingly over the years is bring more sort of user feedback on board and usability testing and so forth. At the beginning, it was enough my own personal experience and then working with a few doctors and gradually. But now, of course, we have to work a lot with the end consumer and understanding their needs and so forth. But really, I've been driven by that first-hand experience, by a deep understanding of the need for clinical quality, accuracy, safety, and so forth. And that's driven everything that we do. And we have a lot of people within our organisation that are responsible for that, whether that's our medical knowledge engineering team, which is a big team of doctors, clinical evaluation, medical safety, patient safety. We have a lot of clinicians on board.
And obviously the kind of realm of AI in healthcare is so new as a whole, not just Ada Health, but other companies in the space, other products in the space, that, one bad story about a different product could potentially affect the trust in your product. If there are negative headlines about AI and healthcare, that's going to affect you all. What do you do to kind of support the ecosystem as a whole and prevent, one bad incident from threatening everything?
Yeah, I think you're right. I think that's a real risk in any industry. And we've seen examples of that in other industries, and you see it in healthcare too. And therefore, I think there's a couple of really important things that we do. So one is we actually work closely with the wider community on topics such as evaluation and producing evidence and benchmarking. One example of that is that we're actually leading a stream within a big initiative run by the World Health Organization around benchmarking AI in healthcare. And within that, there's a stream for AI-powered symptom assessments, and Ada is leading that stream. But we have, as part of that group, academics, industry stakeholders, experts, and a lot of other companies that are working in our space, so our competitors. And we work closely with them on this topic of What does good look like? How do we measure accuracy and safety? How do we benchmark these products, and to really sort of drive that forward and be thought leaders in the space. I think that's essential, and to work together on that, to try and pull everybody up to a certain level, a certain standard, and level of practicing. I think the other thing is having a voice, being very open and transparent, being proactive in our messaging, talking about these things, what we do with, what we do with your data, what we don't do, why that's in your best interests, who we partner with and why, our mission and goals. You're basically sort of being very proactive in driving trust in the space in general. I think it's these things. Mm-hmm.
I'm trying to think of an example. And one that comes to mind in health tech is maybe something like Google flu trends, which obviously people had a lot of hope in to begin with and then didn't quite play out as expected. How do you avoid making the same mistakes?
Yeah, well, Google flu trends is an example of how Google. So basically there was a lot of excitement around its potential because it appeared to be identifying flu outbreaks sort of earlier than the standard methods of notification and so forth. But of course it was driven by data and sort of pure machine learning and association really between searches and then outbreaks, and in the long run it wasn't as accurate as it had been hoped, and had to be closed down. I think what's important to note about our approach is that we do not use a pure machine learning approach, and we don't think that we're very confident that would not be the right approach to use in our field and to solve the problem that we are solving. So one of the very important things to do is make sure you're using the right technology to solve the problem that you're trying to solve. So Ada uses an approach which is, we've built an enormous knowledge base, we couple it with a reasoning engine and a questioning algorithm, and we have human experts basically continuing to curate and improve that knowledge base. So we may pull in knowledge from the literature using natural language processing and so forth to make that really scalable and efficient. And we also have feedback loops that use machine learning where we're learning from user feedback and interactions and behavior and so forth. All of this makes the whole process far more efficient and you can really scale it up, but we always have humans in the loop checking this, making sure that that we're continuing to improve the knowledge. What we don't allow is data from one hospital or one system or individual diagnoses to completely sort of alter we don't allow automatic learning on that data that then automatically changes the knowledge base, because we believe that would really risk bringing in bias and errors and so forth, and it's not the right approach in our particular space.
Bias is another area that we've seen a few kind of controversies in health tech, perhaps different suggestions based on gender or race or age, things like that, which maybe aren't medically helpful. How do you reduce bias in your knowledge base, in your data sets?
Yeah, and that would be a real risk if you trained a system just on data from, let's say, the electronic health records of one hospital. Then there's a real risk of creating a very biased system based on the bias of, the doctors in that particular hospital, the protocols that they use, maybe the drugs that they're encouraged to prescribe. Often we see in electronic health record data that there's systematic bias because doctors are coding symptoms and coding diagnoses for billing purposes, and they upcode in order to be able to bill more, rather than perhaps really going for the most accurate potential diagnosis. So you just do not want to train a system on data that could be biased and amplify that bias. So that's exactly why we take a different approach, and we work with existing best knowledge, best practice, whether that's textbook knowledge, the literature, and a large network of experts with experience. And what we also do is we fill that knowledge not only with condition and sort of symptom-specific knowledge, but also knowledge about how diseases present in different parts of the world or in different groups of patients, prevalence and incidence data. So some diseases are far more common in one part of the world than another, and Ada knows about that. So Ada will understand, if you have a certain ethnic background, if you have a certain medical history, conditions, risk, or if you're in a certain country, then the risks of certain diseases are different and will behave accordingly. So we avoid that kind of bias by making sure that the knowledge base is built with that nuance from the ground up and takes all of these different factors into account.
So Ada will make mistakes. There will be times when a less than optimal suggestion will perhaps result in a less good health outcome for someone, maybe even with quite damaging effects. When that happens, how do you sort of minimize the loss of trust in the product or even try and regain it back?
So I think first it's important to point out that Ada doesn't make a diagnosis. So Ada never provides one answer, one possible condition as the cause of somebody's symptoms, and it's always very clear that there's a range of possibilities, lists the probabilities next to them, says it could be something else, and we also do a lot of safety netting, helping people to understand what they should do if things get worse or they develop new symptoms and so forth. Of course, no system is perfect. Doctors are not perfect. Doctors don't always know what you have, and so that's why this sort of system of safety netting and making sure that if things get worse, you go somewhere else is important. And doctors have developed that, and it's the same for us. But in the same way that people still trust doctors, even though no doctor is perfect and always going to know exactly what you have and tell you where make the right decisions. I think it's really important about just being clear what's very important for us is being very clear about what Ada does and what Ada doesn't do. So being very clear about the promise, not over-promising. Being very clear that this is not a diagnosis, these are possibilities, these are things that might be appropriate, here's the safety netting and so forth. We also have a lot of systems in place. We have a medical safety officer, patient safety officer, we have clinical governance board. We're constantly reviewing feedback from users, any information we have about outcomes and what happened after they used an Ada assessment. And so we look for instances where we think maybe Ada's information could have been better, where there maybe are some gaps in the knowledge base and so forth. So we're constantly looking for ways to fill those gaps and improve and learn, and we have a lot of systems in place for that. And I also think it's about communicating that to the individual so that people understand what are the limitations, what's the promise, what are the limitations, what are you doing to try and continuously improve and stay safe, and if there are ever if there's ever any feedback that something wasn't as a patient expected, being very proactive about dealing with that and being open and transparent.
Do you think people have higher expectations of the AI product than they would of a human doctor in the same way they do of driverless cars versus human drivers?
Yeah, that's an interesting question. I think people have different expectations, and it's about being very clear, as I said, what to expect, not over-promising, being clear, making that clear not only in all of your messaging, the website, and when we're working with partners, explaining, but through the process of interacting with Ada. What we do see is that a lot of people tell us they're far more open with Ada than they feel they can be with a GP, so there's this element of trust there, I suppose, in that it feels safe to be very open about symptoms that might be embarrassing or sort of usually stigmatized. Examples of mental health, sexual health. We do get a lot of feedback from people, even when we've rolled out Ada in partnership with primary care practices in different parts of the world, we get feedback that the patient felt comfortable sharing certain things with Ada, and then even though Ada was then maybe going to share that with their GP if they made that request, they somehow felt more comfortable having that conversation with Ada than they felt having it with a doctor, which is, I think, interesting.
Yeah, that's really interesting. And you mentioned Ada's active in lots of different countries, different languages. Are there differences in that trust question and how people interact with it, how you earn trust from people in those different geographies?
So I think one thing we certainly notice is that we get a lot more repeat use from individuals when the app is available to them in their own language. So early on, when the app was only available in English, we saw that we were getting a lot of repeat use from people who were probably native English speakers in the UK and the US. We had a lot of downloads in India because there's a lot of people who speak English there. But when people were using Ada in other countries and they probably weren't native English speakers, maybe there was much higher drop-off. And we've now rolled out many languages: German, French, Spanish, Portuguese. The most recent and others, and the most recent is Swahili just some days ago. And of course, when people are using an app in their own language and it's really sort of customized for that area as well, this drives trust and this drives greater use. And for example, I mean, with the Swahili that we've just done that translation in partnership with Foundation in East Africa, and we're doing work in Tanzania. It's not just about translating into the language, it's making sure that we're adapting for local conditions, the prevalence of diseases in that country, how diseases present, cultural nuance in how you interact and have a conversation with an individual. And we work with doctors, always clinicians, to do those translations, but local clinicians who are native in that language and trained in that country. So we have people in-house with us in our offices, but also local clinicians who work with us to do that. And that's so important.
Thank you very much, Claire. We're out of time. Claire Novorol from Ada Health.
Thanks very much.